So hybrid is doing a graft, doing a Tommy John operation, but then adding some kind of extra something. And the extra something has a number of different forms depending on who's doing it. Some of them involve anchors, some of them don't, some of them involve just sutures, some of them involve tapes. Hybrid is very hybrid, but it's kind of a combination of reconstruction and some type of augmented repair.
Stephania Bell from ESPN here at AOSSM in Nashville 2025, and I am thrilled to be joined by Dr. Jeff Dugas, Managing Partner at Andrews Sports Medicine Clinic and Orthopedic Center in Birmingham, Alabama. More importantly, my friend. Full disclosure, has operated on my left knee not once but twice, so I might be a little bit biased in this conversation, but I appreciate you taking some time out. I know how busy you are.
Thanks for having me. It's always great to spend time with you.
So let's get right to one of the hottest topics in sports medicine right now, UCL primary repair, UCL repairs. And given its rise in popularity to the point that it is now part of the vernacular, not just among sports medicine people, but sports fans, a lot of folks might not know that you are the pioneer of UCL repair with internal brace.
That's kind. I adapted something that another surgeon in Scotland, he's a foot and ankle surgeon named Gordon Mackay, had done. He had taken these implants that were kind of different and put them together in a construct and called it an internal brace and did it in the ankle. And I said I thought we could do this in the elbow, and timeliness was important because Dr. Andrews had kind of pushed us, myself and Lyle Kane, to kind of figure out what can we do different, because we were doing Tommy John surgery on all these kids, and we only had one answer for every injury, and there's so much of a spectrum of injury when you see these things that it was just sad we had to do these big operations on all these kids. And so I pushed the company that made it to really see if we could do this, and they accepted the challenge. They sponsored some research. We did some basic science stuff. We proved that it would work in a cadaver model, and we pulled on it and pushed on it and tugged on it and did everything we could to prove it, and then we did it in the human for the first time in August of 2013, and we're coming up on 12 years, and it's been an incredible experience to watch my colleagues around the country, who I have a lot of respect for as elbow docs and sports docs, see this be valuable in their patients as well as mine. That's been the biggest reward of the whole thing.
I do remember back when we were talking and you were talking about having found patient zero, your original patient that you did this on, and it's cool to see how widespread the procedure has become. In a few sentences, can you describe the difference between the repair versus the original Tommy John surgery, and then your criteria for the folks who you choose or select for repair?
So Tommy John surgery, reconstruction, the term reconstruction means you're taking a piece of tissue to make it into something else. And typically in the body, if you're doing ligament reconstruction, you're using a tendon. This is true for ACL reconstruction, ankle ligament reconstruction, Tommy John, UCL reconstruction. You're using a tendon, and you're putting it into drill holes into bone or on bone, and you're asking it to transform, to heal first, and then transform into ligament. Tendons and ligaments are similar, but they're not the same, and that transformative process, that ligamentization process, takes a pretty long time, 12 months-ish. And so the repair is different in that we're not putting a graft in, we're not putting something in there that has to transform. We're repairing the patient's native tissue back to where it came from and augmenting it with a synthetic, biologically enhanced tape, which is very, very strong. And so the criteria, and that's where the importance of this is number one, it has to be torn off of one end or the other. It doesn't make sense to repair it in the middle. That doesn't heal very well. So ligament to bone healing is very reliable and predictable. Ligament to ligament healing, not so much. So it has to be an end avulsion, ligament torn off bone. The tissue has to be good tissue. It can't be beat up old tissue or tissue that there isn't enough of, or there's missing tissue. There has to be no tissue deficiency. And I think, importantly, you have to have a benefit from a shorter recovery. It is a shorter recovery because you're not asking it to transform into something, but if you don't have a benefit from a shorter recovery, then why do it? So I think Tommy John surgery, the way Frank Jobe and Jim Andrews popularized it, and Dave Alchek, it's still the gold standard. It's a great operation. But if you don't have a time benefit, why not do the gold standard? And so that's kind of the three criteria: end avulsion, good tissue, time benefit.
What are the latest numbers when it comes to the success rate of the repair procedure?
So we published an article. We were very honored that Brett Owens, the new editor of the American Journal of Sports Medicine, which is the trade journal for us, he published this as the lead article with his first editorial in March this year, a follow-up study of our repairs and compared to our reconstructions. So the reoperation rate was the same in both groups, and the success rate was the same in both groups getting back to play among those who attempted to get back to play. So 98, 99% of people that attempted to get back to play got back with both operations, and somewhere between 8 and 9% reoperations. Interestingly, the reoperations in that group, the redos that had to be redone to a stability operation, so to really redo the operation that was done the first time. So if you had Tommy John surgery and it failed and you had to have another Tommy John type of procedure, in the reconstruction group, there were more redos than there were in the repair with internal brace group. So more people in the percentage-wise, a higher percentage of people in the recon group had to have a second operation for stability. But the total reoperation rate was the same. Sometimes it's a nerve thing, sometimes it's a stitch or bone forming. There's different reasons why people have a second operation, but to redo the whole thing, it was a little higher in the reconstruction group, which was a little surprising.
So is it fair to say that the failure rate so far for the repairs is significantly less?
I would say it's very low, and I come up short of saying it's better or less than the reconstructions, because I think that's unfair, because we cherry pick the repairs. And as I said, the repairs have criteria to them. So the way I say it to patients is Tommy John surgery fits all, repair with internal brace fits some. So we are cherry picking the ones that fit internal brace to do it on. I think if you applied it without any lens and just did it equally in all population, I don't think the numbers would be the same. So I think that speaks to the need to have strict criteria to do the operation.
Now, lately, we've been hearing, in addition to the repair, obviously the original Tommy John reconstruction, we're hearing about this third option, this hybrid. Can you describe that, and what are the indications for that?
So it's interesting, because as of today, hybrid is kind of hybrid. There's probably 20 different ones out there. So everybody has a different brand of the hybrid. So hybrid is doing a graft, doing a Tommy John operation, but then adding some kind of extra something. And the extra something has a number of different forms depending on who's doing it. Some of them involve anchors, some of them don't, some of them involve just sutures, some of them involve tapes. Hybrid is very hybrid, but it's kind of a combination of reconstruction and some type of augmented repair. I think that it's a good idea in that I don't think it's going to hurt anything. I think there's no real downside risk. I think that having a graft means you have to let it incorporate and heal. So I don't think it's going to shorten the recovery time. And I don't think teams in general are going to see a faster return to competition with this, because it's not going to make the biology of that graft incorporation happen any faster. Is it going to provide protection for the graft? Are we going to see less failures with a hybrid versus just a reconstruction? Maybe. And I don't think we have the data on that yet. I think we'll have it in 5 to 10 years, but it's possible that this may cut down on some of those failures which have been problematic.
I wonder if there will be more of this hybrid type procedure on revisions.
I doubt it, because you already have so much mass of tissue. Right. That adding more tissue, you're almost changing the plane of the pull. Unless you debride the previous repair or reconstruction, you're dealing with a pretty thick bunch of tissue. And I think adding more tissue to that is probably not necessarily going to. Revisions have not done well at all. So the revisions with the internal, but just doing repair of the torn previous TJ has actually worked really well. It may be tough to do that with a graft the second time. I think you're creating an off-plane stress.
Interesting.
Too much bulk.
Biomechanics
Biomechanics.
at work, which pitchers, in particular throwers who make up the majority of the population, they care deeply about that.
They do.
So. All right, well, thank you, Dr. Dugas, for spending a few minutes with me here at AOSSM.
Happy to do it as always.